Greetings from Sydney, and many thanks for the invitation to be part of this important meeting. And on behalf of Isakos, I'd like to say that we're very proud to be affiliated with this meeting and support what I'm sure will be an excellent educational meeting for all participating. And greetings to all of our good friends in India. I'm going to talk about my thoughts about osteotomy around the knee. These are my disclosures. So achieving optimal outcomes with osteotomy requires appropriate patient selection, clear goals for the procedure. It needs to be a safe procedure with minimal risk of complications. It needs to be fairly easy, accurate, and reproducible to do, and allow an accelerated recovery and lead to predictable outcomes. So if we can start with discussing who should have an osteotomy, the indications for osteotomy are quite broad, the most common being arthritis in a younger and more active patient, patients who have meniscal deficiency or chondral pathology, such as this patient here having chondral treatment and offloading it with an osteotomy, patients with instability, patients who have malalignment that's affecting their instability, needs to have that corrected as well as a ligament reconstruction. This patient who had significant genu varum and had medial tibial plateau stress fractures that were unresponsive to non-surgical treatment was corrected to neutral alignment and had an excellent outcome. And then other more unusual cases, such as this patient who had a deformity in the sagittal plane, requiring a corrective osteotomy to reduce the recavatum and the instability associated with that. So there are many indications for osteotomy beyond osteoarthritis. Patient selection, so predictors of outcome, if we look at the literature to achieve a long-term clinical outcome, best results are with patients with a lower age, a lower BMI, good range of movement, and a relatively low osteoarthritis grade, and obviously good condition of the lateral compartment. So this does create an argument for earlier intervention if possible. We've done our own studies and looking at our own results, and things that compromise the outcome are patients who are overweight, patients who are stiff, and patients who have more severe arthritis and deformity, again, supporting the argument for earlier intervention. So the ideal patient for osteotomy is someone who has well-localized pathology and symptoms, usually with mild to moderate arthritis rather than severe disease if possible. Minimal stiffness, they ideally are a healthy weight. I won't do the procedure on smokers, and they have to have appropriate expectations. They need to understand they will get a significant improvement, but it won't be exactly normal. They should expect a high procedure survival at 10 years, and it shouldn't compromise a subsequent knee replacement. If we now look at the evidence base for osteotomy, this is our own series of over 200 patients, predominantly male, with an average age of 49 years of age and correcting from about 5 degrees average varus to 2.5 degrees of valgus. And we look at their outcomes across the KOOS score, every domain showed a significant improvement. So we're getting improvements and the patients usually are happy with their improvement. If we look at this graph, the gray lines represent age-matched norms. So people with normal knees, so this is an important graph. We can demonstrate to patients that we can make them a lot better, but we're not making them exactly normal in patients who've got osteoarthritis. If we look at procedure survival in our series, we had almost 100% at 5 years, but it reduced to 80% at 10 years. When we analyze this and we look at our patient selection, we think we could probably improve this to better than 90% with better patient selection. The next question is, what alignment should we aim for? Is it one size fits all, or do we need an individualized correction prescription? So where currently is really no consensus on the optimal selection of correction angle in osteotomy, if you look at the literature. And people base their decisions on a number of things, including the effect on long-term survival, the effect on knee scores, lateral cartilage wear rate, and also studies using motion analysis and EMG. So we've done a lot of studies around all of these areas, which I'll try to share with you. The traditional recommendations are for an overcorrection beyond neutral. I think we all accept that. If we look at Coventry's recommendations, it was around 3 to 5 degrees of valgus. And then in more recent times, people have largely accepted the Fujisawa point at 62.5% of the width of the tibial plateau, which equates to about 2.5 degrees of mechanical valgus. Now, we've done our own simulations using a computer model, looking at what happens to the loads in the two compartments as you go from varus to valgus. And interestingly, we found that the loads equalize between the two compartments at about 1.5 degrees of mechanical valgus. So this would support that you have to go a little bit beyond that to really offload the medial compartment. We've done gait studies looking at the preoperative adduction moment, which is the abnormal load on the medial compartment of the knee. And we showed that if we correct people to 2.5 degrees of mechanical valgus with navigation, we eliminate the adductor moment. So further support for that alignment indication. We've also looked at articular cartilage changes in the same group of patients, showing that we do get an improvement in the medial compartment articular cartilage over 2 years. Again, if we correct them to approximately 2.5 degrees of mechanical valgus in patients with well-established osteoarthritis. So that gives us some indication for what we should be doing in patients with arthritis. More recently, we've looked at the effect of joint line obliquity. So prior to osteotomy, the patients have a certain obliquity to their joint line. And when we do a correction on the tibial side, we're completely changing that obliquity by affecting the proximal tibial articular angle. And we looked at 21 patients and we looked at their joint line obliquity, as you can see here, pre and then post, and it significantly changed, and it changes on the tibial side, not surprisingly. We don't affect the femoral side. And so the opening wedge osteotomy increases the joint line obliquity by increasing the medial proximal tibial angle, and this is what creates the more valgus knee alignment. Now, if we look at the actual effect of this, if you look at the seesaw analogy, when we have the same load, but we add in some obliquity, then we increase the load on the lateral side of the knee. So it may be that by having obliquity, this has an additional effect on the loads on the lateral compartment beyond just the valgus. And people have looked at this before. Coventry recommend we shouldn't go more than 10 degrees of obliquity, and there are other cadaveric studies suggesting that increasing the joint line obliquity by too much may be an issue. So when we did this, and we looked at a computational effect using a modeling effect to look at the independent effect of the joint line obliquity, we looked at patients at 1 year post osteotomy. We used a computational pipeline to quantify the individual effects of changing the alignment and changing the joint line obliquity. And we used an regression analysis to examine these independent effects. And it's quite a complex analysis, but I'll summarize it for you, that there is an independent effect of joint line obliquity. If we look at the effect of valgizing, that increases the compressive load change on the lateral compartment, and there is an isolated effect of the joint line obliquity on this lateral compartment load. So in summary, there is a significant independent joint line obliquity contribution to the lateral load, and therefore we need to think about how we do osteotomies if we're going to think about HTO survivorship. So if we look at the correction prescription, when we're trying to individualize the correction depending on a patient's pathology, in general, the guidelines for patients with established medial compartment arthritis will usually aim for 2 to 3 degrees of mechanical valgus, which is roughly the Fujisawa point. If patients just have early arthritis or chondral lesions or meniscal deficiency, we can go a little bit less, maybe 1 to 2 degrees of mechanical valgus. If we're doing it for instability and we're doing a ligament reconstruction, we should correct them to neutral. If it's lateral compartment disease and we're offloading the lateral compartment, we also tend to correct them to neutral. And it's important, as I mentioned before, when we're doing this, to do your calculations to try and avoid excessive joint line obliquity. So how do we achieve that desired correction? Now we've decided what we want to do with our correction. So we need precise tools to do this and precise intraoperative assessment. So we can do this by preoperative calculations and using techniques like you see here, like the Miniachi technique and the Fujisawa point. And we can do techniques intraoperatively. We can use the fluoroscope and we can use visual assessment of the leg. But there are limitations. So preoperative osteotomy plan is made from static long leg x-rays. There can be variability, there can be soft tissue laxity, and they don't incorporate the dynamic alignment of the knee or the patient-specific anatomy. So a long time ago, I realized that there were these limitations, and therefore I started looking at using computer navigation for osteotomies, as I was already doing with total knee replacements. And ever since about 2006, I've used navigation for my osteotomies, and we've published on this. So I felt that it would be more accurate, it would probably improve outcomes. We can look at someone's alignment through the full range of movement, not just full extension, and we can look at the coronal and sagittal planes with navigation. So for example, here, when we do a traditional long leg radiograph, we're just looking at the patient in full extension. But if they have more posterior wear in their arthritis, then you may see this alignment only as you flex the knee. So this example here of someone who's in neutral alignment in full extension, and they have posterior medial wear and they go into varus. It's not very common, but it does happen. And you can pick this up and assess this with your navigation system. And also we can look at the sagittal plane. So we don't directly measure the sagittal slope with navigation, but we can look at the extension that patients have pre and post correction. So for example, this patient has a 15-degree varus deformity and a 3.5-degree flexion contracture. And when we've corrected them to 2.5 degrees of valgus, they have the same flexion contractures. So we can be fairly confident that we haven't increased the tibial slope because they haven't lost any extension. And if we look at the literature, there's a reasonable amount of literature on navigation for osteotomy, not as much as there is for arthroplasty, but in general, there are variable results, but the majority of studies show improved accuracy and reduced outliers when compared to manual techniques. So there's quite good evidence for using navigation. So this is what I have a setup for tibial osteotomy. So you can see the pins percutaneously in the tibia and the femur, and the incision for the proximal tibial osteotomy in between. And then when I do a femoral osteotomy, here you can see the opening wedge femoral osteotomy, and the navigation trackers are in the same position. The registration is done via the center of the hip with a standard kinematic registration, the same way we do with the arthroplasty technique. The center of the knee is done arthroscopically, as you can see here, and the center of the ankles is done by the malleoli. We can then get our initial alignment. We can look at the effect of soft tissue laxity, and we stress into varus and then stress into valgus, and then we can compare this and validate it against our preoperative calculations. And then we do the osteotomy, and once the osteotomy is complete, we can check our alignment again with the navigation system, just to be happy that we've achieved what we want to achieve. And when we first started using navigation some time ago, we validated this by looking at all of our postoperative long leg alignment x-rays after 6 months, and showed a very good correlation between the navigation findings and the postoperative x-rays. So at that stage, we're obviously very happy, and navigation has been my standard practice for osteotomy for about 15 years. And we've published on this, showing how we've used it and showing how we've achieved good results using navigation. But in more recent times, we've transitioned to 3D printed custom guides or patient-specific instrumentation. And the reason we've started to do this is we think that being an image-based modality that's well established in arthroplasty, it allows us better options for improved virtual planning and presumably better efficiency with good accuracy. And if we can show that it's just as accurate as navigation, then I think we can plan the procedures better and do them more efficiently. So I'll just talk you through how we do this. The patient has a preoperative EOS, which is a long leg simultaneous biplanar, so coronal and sagittal plane x-rays that are ultra low dose, and we can look at their overall alignment in the two planes and also measure their tibial slope. And then this alignment data goes into an app, which then allows the surgeon to modify the alignment and change it to the alignment that they want to achieve for the patient, as you see here, either in terms of degrees or in terms of the percentage of the tibial width. And once they've done that in the coronal plane, then we can also adjust the sagittal plane by changing the tibial slope if you want to change the tibial slope. Once that's done, those calculations then are applied to the patient's CT scan to work out the correction angle and the wedge size that we need to do to achieve the correction we want to achieve. And then the hardware position is planned. You can determine the best place for the plate and the screws. It's then closed, and the PSI guide is made for the surgeon to use in the procedure. And the information that the surgeon will get will be the pre and post-operative alignment, the pin position that they can correlate to the fluoroscopic pictures during the procedure, the depths of the saw cut, and also the screws, and then also the wedge size anteriorly and posteriorly. So it gives a lot of information that the surgeon can double check during the procedure, just to make sure that we're achieving an accurate procedure. And so this guide is then used. You can see here that on this occasion, I'm using the PSI guide at the same time as navigation to double check. The osteotomy is done and then completed. And we've done about 53 of these cases using the PSI along with navigation at the same time. and look at the correlation between the two systems, then we've been very happy that it is actually very accurate and equivalent to navigation. So we've transitioned away from using navigation for all cases to using the PSI for all cases. I'll give some examples just to demonstrate how we do the procedures. This is a patient who has a severe varus deformity. You can see their weight-bearing line is falling well outside the joint. So when we plan to do the correction just on the tibial side, you can see we create a very oblique joint line and a very large wedge size, which I wasn't happy with. So we then plan to do a double osteotomy by doing an opening wedge on the tibia and a closing wedge on the femur and maintaining a relatively neutral joint line. So we have a PSI guide to do the closing wedge on the femur and the opening wedge on the tibia. The femur is done first, followed by the tibia. And then this is the alignment that we achieve. And this is the patient at about 8 weeks post-operatively. And we've been very happy with the alignment and the outcome that we achieved there. And we've done that, as I mentioned before, without creating a very oblique joint line. And when we look at motion analysis, we do for all of our patients, we can show a big decrease in the adductor moment. And you can see the ground reaction force on the left side of your screen is very medial, whereas on the right side after the correction, it's very much more neutral. So that's exactly what we're trying to achieve. This next patient had a valgus deformity, so lateral pain, previous lateral meniscectomy, and had valgus alignment. So they were planned for a lateral meniscus transplant, but also needed to have their alignment corrected. If you look at the tibia, it's quite valgus within the tibia, so we elected to do the correction on the tibial side with a closing wedge on the medial side of the tibia, and we can calculate the size of the wedge that needs to be removed. The procedure is done along with a lateral meniscal allograft. A third case, this is a pediatric case with a recurvatum deformity from a growth arrest. If you look here, this is the slope, the very abnormal slope on the affected side. So we calculate the angles there. We then do a scan of the other side to know what we're trying to correct it to. We then plan the correction, mostly in the sagittal plane. We make a PSI guide to do the tibial tubercle osteotomy and drill the holes for the plate. A second guide will allow us to do the anterior opening wedge osteotomy. And a third guide allows us to cut an appropriate size wedge to fill that gap from an allograft. And then the procedure is complete. So again, very easy to plan and do the procedure. If you can do this all prior to the surgery, it makes it very predictable. This is another case with severe post-traumatic deformity. You can see this patient had a motorcycle accident in her teenage years, has ended up with a very deformed leg with a very incongruent joint, some valgus on the femur and varus at the knee joint. So we didn't want to do a total knee replacement on this person, particularly they're very young and a very, very difficult knee replacement. So we elected to correct their deformity. We decided to correct the femur to a neutral alignment with a closing wedge osteotomy, and the tibia be an opening wedge in both the coronal and the sagittal planes, a very big correction. You can see here 20-degree correction in the coronal plane and in the sagittal plane. And this is what we're aiming to achieve. So there's a PSI guide for the tibia to do the opening wedge osteotomy. And this is what she looked like prior to the procedure. And then after the procedure, well-corrected alignment and a much more congruent and well-aligned joint. So she's had a good improvement, and it will also serve as a much better platform for a knee replacement in the future. And a final case, this is a valgus deformity with ACL insufficiency. So again, a patient here who has a valgus deformity, and we need to do an ACL reconstruction at the same time. So you can see here that we've planned the osteotomy with a PSI guide, and we've also planned it away from where we know the femoral tunnel of the ACL will be. So we can plan this as well. And the patient has the opening wedge osteotomy on the femur, as you can see here, and then the ACL with the femoral tunnel lying in behind the plate. So all this can be very accurately planned. So in conclusion, achieving optimal alignment is critical to the outcome of osteotomy. I think navigation has been very good. It's helped improve our accuracy. We've recently, as I've said, changed to 3D custom guides. I think it has equivalent accuracy to navigation. It allows us improved planning potential, particularly with the more complex cases. And it does provide improved efficiency over navigation with an easier, predictable technique. But however, I still think there is a role for navigation, mainly as a secondary check in more complex cases or bigger corrections. So to achieve optimal outcomes with osteotomy, we need to have appropriate patient selection, clear goals, as in what are we going to do, why are we doing it, and how are we going to do it. It needs to be safe with minimal risk of complications. It needs to be easy, accurate, and reproducible, which for us is mostly PSI and occasionally supplemented with navigation. And we also need to add appropriate supplementary procedures. For example, we recently started to do some work looking at stem cells in addition to osteotomy, as a study that we can hopefully report our results later. And it needs to allow a very personalized recovery and good rehabilitation. So I'd like to thank you for your attention and wish you a wonderful meeting. Before I finish, I'd like to invite you both to our arthroplasty meeting, which will be in Chile later this year, and even more importantly, to our ISAKOS Congress, which will be in Boston in June of next year. Thank you for your attention.